Carrie Shorey is a PhD student in the School of Public Health and Health Systems at the University of Waterloo. She has a particular interest in the areas of stress, inflammation, cognitive decline, and health inequalities. Her past research has looked at how multiple chronic conditions impact cognition in aging adults. Carrie's research includes how chronic inflammatory diseases and their pharmacological medications impact cognition and cognitive structures. Carrie is also interested in how chronic stress early in life may be associated with cognitive decline in middle age. Carrie completed her MSc at Purdue University and her BA at the University of Guelph. And our today's author is Dr. Austin Zygmunt. He is a fifth-year public health and preventative medicine physician at the University of Ottawa and practicing family physician in Ottawa. As a public health resident, Dr. Zygmunt has supported the COVID-19 response at Ottawa Public Health, the Public Health Agency of Canada, and most recently the Public Health Ontario. Dr. Zygmunt completed his family medicine residency training at the University of Ottawa in 2018 and has special interest in LGBTQIA health and sexual health. He completed both his medical school and Master of Science in Community Health and Epidemiology at Dalhousie University. His research interests include marginalization, health inequalities, preventable health outcomes. His research to examine association between marginalization and avoidable mortality in Ontario is supported by a grant from Briere Big Data Research Program. And I'm going to pass this over.
The University of Waterloo. And today I'll be presenting part of a paper on neighborhood level marginalization and avoidable mortality in Ontario in collaboration with the author, Dr. Austin Zygmunt, and his other colleagues. Sorry, just one second. There we go. All right. So although many studies have been performed on marginalization, the nuances of the term is pretty limited. Marginalized groups have been defined as a population outside of mainstream society and highly vulnerable populations that are systemically excluded from national or international policy-making forums. So the main objective of this study was to examine the relative impact of the 4 dimensions of neighborhood marginalization on avoidable mortality for the entire populations of Ontario. The purpose was really to assess population health with neighborhood level research compared to the more traditional patient-centered factors. So avoidable mortality are those deaths that are occurring in individuals who are younger than 75 years of age and that could have been prevented or treated. So these preventable causes are deaths that might have been avoided through vaccinations, lifestyle changes such as quitting smoking, or injury prevention. Additionally, treatable causes are deaths that could have been avoided through effective screening or treatment of disease, such as catching breast cancer early and getting the treatment that is needed. So differences in avoidable mortality between places and groups can help us see where the health system has made gains and where more work is needed. Indicators of avoidable mortality can provide a general starting point to assess the effectiveness of public health and healthcare systems in reducing premature deaths from various diseases and injuries. Many marginalized groups have barriers to accessing healthcare, and marginalized groups are at greater risk of avoidable mortality. So First Nations and Inuit have been found to be at greater risk of avoidable mortality, whereas immigrants and those with higher incomes have been shown to have lower avoidable mortality rates. Additionally, women compared to men and rural communities compared to those urban tend to have lower rates. So ICES administrative data was used from 1993 to 2014 in Ontario, and they calculated the premature deaths that were occurring during that time. And it turned out to be just over 460,000 individuals who had passed away or died from avoidable mortality. This study was a population-based investigating premature deaths. The Office of Registrar General deaths was used for the primary cause of death, They excluded those with no Ontario Marginalization Index, deaths that occurred at age 75 or after, no recorded postal code 12 months prior to their death, those who were ineligible for OHIP coverage 12 months prior to death, and those who didn't have a cause of death recorded. The independent variables included age, sex, location, which is that rural and urban, and level of comorbidities. Records missing at least one of the variables of the above were also excluded from the logistic regression analyses. So the Ontario Marginalization Index was the main exposure of interest for the neighborhood marginalization, which was measured through 4 dimensions, including dependency, ethnic concentration, material deprivation, and residential instability. The first dimension is dependency, and this is measuring population that's eligible to participate in the workforce, but who may not be working. The second dimension is the ethnic concentration. This is the proportion of a neighborhood that might be recent immigrants or visible minorities. The third dimension is material deprivation, and this is the proportion of the population in the neighborhood that have a lower income, lack of a high school diploma, and may be made up of single parent families. And then lastly, the fourth dimension is residential instability, which is a measure of neighborhood quality and social support. And this includes proportions of those living alone, moving frequently, and may have home overcrowding. So the study found that approximately 67% of the deaths recorded were preventable or treatable, and that men were almost twice as likely to die from preventable deaths than were women. However, this was reduced significantly for treatable causes. Using quintiles for the 4 dimensions, the study found that in general, there was a dose-response relationship in that the greater the material deprivation, dependency, and residential instability, the more likely avoidable mortality occurred. Ethnic concentration had a reverse effect. However, once it was adjusted for age, sex, location, and levels of comorbidities, we found a little bit of a different result. Those with greater material deprivation and greater residential instability were more likely to die from avoidable mortality, particularly preventable causes. Interestingly, those neighborhoods with high dependency and high ethnic concentrations were less likely to die from avoidable mortality. And when the deaths in the dependent or highly ethnic concentrated neighborhoods were occurring, they were more likely to be from treatable causes. So first, this study had a couple of limitations. The Ontario Marginalization Index was based on the 2001 and 2006 census data, and there are concerns that the accuracy is greater closer to those timeframes rather than at the extreme ends, such as 1993 or 2014. Secondly, the Ontario Marginalization Index assigned a summary level of neighborhood marginalization to those that had died, which may not actually reflect the individual level of marginalization. Third, an overestimation of marginalization could have occurred due to the exclusion of the Ontario Marginalization Index of postal codes after new postal codes, after 2006. And lastly, the dimension of marginalization wasn't able to be stratified into each of their own constructs to quantify the association of avoidable mortality. So implications of this study were really that it was able to provide a lot more nuance regarding the drivers of preventable and treatable causes of avoidable mortality. There were clear gradients of ascending and descending results for preventable and treatable causes. The study also supports that notion that socioeconomic inequities tend to be greater for avoidable mortality from preventable causes than from treatable ones. For instance, this study found that material deprivation has the greatest association with avoidable mortality, particularly for preventable causes, which could be a major target area for future public health and policy interventions. And importantly, this article contributes to reducing health inequalities and improving avoidable mortality outcomes at that neighborhood level. So I apologize, I went a lot faster than I thought I was going to, but a lot of the topics are going to come up more in conversation as we discuss some of the important questions and really getting into the paper more. So at this point, I'm going to stop sharing, and maybe Austin and I can have this deeper conversation regarding the paper. So first off, I know for many of us, we shouldn't be really surprised at the consistency in the avoidable mortality outcomes as we know, specific marginalization categories are more likely to have worse health outcomes, greater mortality outcomes. But I still found it extremely shocking just to see it, that those quintiles and just how each level it just kept increasing or just kept decreasing. So for instance, the fact that there were almost 58,000 additional avoidable mortality in the material deprived neighborhoods, it was a lot to see those numbers, which is it's almost just sad. So why did you feel that it was important to make the connection between avoidable mortality and neighborhood level characteristics if we essentially know so much about it already?
Sure. Well, thanks for the overview, Carrie. I'm looking forward to the discussion today. So when I first started this study, it was at the beginning of my residency training back in 2016. And I was very lucky at the time to connect with two population health researchers at the University of Ottawa. So Dr. Peter Tanasaputro and Dr. Claire Kendall. And they were really supportive of me drafting my own research question as a trainee, which was really great learning experience. So like many of us in public health, I'm interested in addressing health inequities for marginalized populations and reducing avoidable health outcomes, and then looking at those health problems at a population level. So I was doing some reading back at the beginning of my residency and looking at a Kai report on health indicators and came across avoidable mortality, which was an indicator I hadn't heard of before, but I thought it was super interesting. And then as I kept doing more and more research into avoidable mortality, I came across all these studies about individual level factors. So how income can affect your avoidable mortality and how your education level can affect it. But I didn't really find a whole lot at the population level or the neighborhood level. And at the same time, as it was early in my training, was learning about the built environment and finding out about how much the neighborhood that you live in has an impact on your health status. So when I was coming up with my research question, I really just merged those two things I was really interested in, like why, or is there an association between your neighborhood that you live in and with potentially dying from an avoidable death or a premature death? And that's how it all began.
So I also wanted to ask, one of the limitations that had come up was recognizing that the dependency measure, which you also discussed in your discussion, was slightly flawed, and that even though in the initial analyses, dependency was showing to be similar to material deprivation and residential instability. But then once you controlled for all the other variables, it seemed to go the opposite way with ethnic concentration. So do you think that the dependency results would have been different had you been able to include those over 65 in your analyses, or do you think it might be just very similar?
Yeah, so the dependency dimension of the Ontario Marginalization Index looks at a couple different factors, but it's mainly how well we're supporting people in the neighborhoods that we're living in. So supporting those without an income, how many children are in the neighborhood, how many people are unemployed, that type of thing. And when you look at the actual components of that dimension of dependency, you can see that a lot of them are really age-based factors. So how many young children are there? How many older people there are? So when you look at finding an association between an exposure and an outcome, we were in a situation where our exposure was, being dependency was an age-based exposure, and our outcome was one that was age-based as well. So only considering those under the age of 75. So our best guess of what happened with that is through our statistical analysis that just having those two factors affected the relationship that was seen, because we do comment in the paper that really wasn't what we were expecting. We would expect a lot of these really dependent neighborhoods would probably have poorer health outcomes. And I think other studies that have looked at some of those components previously that don't have not necessarily an age-based outcome have actually found the opposite association that we did, which we've commented on as well.
So are there any dimensions you would have added, removed, or modified to the Ontario Marginalization Index?
Yeah, so when you look at the Ontario Marginalization Index, I find it such like a fascinating composite index of different types of marginalization, and it's not something I was too familiar with prior to working on it with this research. The first time I actually learned about it was at a CPHA conference a couple of years back, where Trevor Venningen, who's one of the creators of this index, was presenting on it. And it's been fairly stable over the last couple of years, and a recent edition of the Ontario Marginalization Index has been published as well with more up-to-date data. So you'll see that we used Canadian census data from 2001 and 2006, but it's since been using 2011 data. In terms of making a recommendation, and then I'm just going to close my door as a rainstorm comes through Ottawa here. I would say that the ethnic concentration dimension, I would want to see having the most change to it. So that really is just looking at two components of ethnic concentration. One, which is a very specific subset of ethnic minorities, so new immigrants in the last 5 years to Canada, which we tend to know from previous research is a very healthy population. Mm-hmm. So to use that as a measure of marginalization, I think wasn't appropriate in this study, as you saw, and could probably benefit from some additions to have more components to look at how ethnicity can affect your marginalization status.
Do you think there might have been a difference between those who are newly immigrant and those, like the measure of like refugees, or even though it asks for visible minorities minorities aren't the same as immigrants either. And so maybe that sounds like it might even have to be another 2 or 3 dimensions added to really get to that nuance.
Mm-hmm. Yeah, so the other component of ethnic concentration is just self-reported identification with an ethnic group. So you're right, that doesn't necessarily take into account immigrants, and certainly doesn't capture groups like all refugees. And when we're looking at other things we could add, I think refugee status would be a useful addition to the dimension, because we do know of poor health outcomes in refugees compared to some of the other, just even compared to new immigrants to Canada.
Mm-hmm. I just want to jump in here and ask a question from the audience.
Sure.
So just speaking about the marginalization index, where would one include a utilization of health services in the marginalization index?
Yeah, that's a good question. I think what would be fascinating to look at with like a future research project would be the association of the marginalization index with utilization of healthcare services or access to healthcare services. I'm not too sure how it would fit in exactly as a component of the index, but I think looking at associations would be neat and not something I've seen done with this particular composite index.
Were there any more questions, Monica?
Yes, one more. Do you believe that a neighborhood level assessment of marginalization is comparable to an individual level of experience marginalization and avoidable mortality? And how could this influence your results?
That's just such a common question in population health research, eh? Do these results at the neighborhood level, do these neighborhood level results reflect what we see at the individual level? And for those that are the master students, you'll probably learn about a lot of those associations or the ecological fallacy in your intro to epidemiology courses. But in the instance of this particular study, a lot of those associations are seen at the individual level as well. So as I comment, or the authors and I comment in the introduction, a lot of this study on avoidable mortality has been done at the individual level previously. So we've seen those with lower income having higher rates of avoidable mortality, and those with lower education having higher rates of avoidable mortality. And then when we look at when those components are made up of the Ontario Marginalization Index, we're seeing similar associations. But I do think it's important to note the differences between individual level associations and neighborhood level associations. And it is important to recognize that sometimes they can be different as well. Particularly when using this marginalization index that covers a lot of different types of marginalization, not just income and education, looked at a lot of different factors as well.
All right. So one of the results that we found, or that you found, not we, were that men were nearly twice as likely to have avoidable mortality from preventable causes relative to women. What type of social determinants may account for this sex difference within the preventable? Because treatable, it was very different.
So when you consider just the health status of men, I think what previous research has shown is that a lot of men have, on average, lifestyle factors that put them at higher risk of having preventable health outcomes. So that can include increased rates of alcohol use, smoking, physical inactivity. And when we look at what are the main drivers of preventable health outcomes that would have been captured in the study, then it does include things like cardiovascular disease, suicide, opioid use, that type of thing, which are also known to be associated with amongst the male sex. And just to comment that this ICS data in Ontario does use sex as its variable for men and women and not gender. Right. I think they're finding ways to move forward with more gender-based analysis.
Yeah.
Another question from the discussion. So do you see this research having direct policy impacts? And how would you recommend leveraging these research findings for policy change for tackling those marginalization factors at a population level?
Get you to repeat that one more time, Monica. Maybe I could look at the question. I see it's from my resident colleague, Dr. in Ottawa, giving me the hard questions here today. So does this research have direct policy impacts? And how would we recommend leveraging these research findings for policy change for tackling those marginalization factors at the population level? So I think that's a super important question, because just when we're doing our usual research as a trainee in public health, we do want our research to have some meaningful impact and not to just stop at publishing in a journal. You want it to go on to have some policy implications. And we won't make this a policy 101 lecture. It can get me off on too much of a tangent, so please stop me, Monica or Carrie, if I start talking too much. But I really think it does depend on what your audience is for this type of research. So this is neighborhood level data, so could certainly be used at city council level to advocate for some change on why things like a healthy built environment or access to parks or access to bike lanes and active transportation are important and have an impact on health. And can also be used in other policy directions as well. So for provincial government, recognizing this was a study across Ontario, and if you want to take provincial action, if that's your audience too, and could also be used, I think, amongst some non-governmental organizations as well to help support some of their advocacy work.
And really, you could also target specific populations rather than having a blanketed policy for all of Ontario. You could hit these specific neighborhoods or target them more readily and easily because now you have this information.
Yeah, with the Ontario Marginalization Index, one neat thing with it, and I encourage everyone to go onto the Public Health Ontario website and just look around at their interactive tool, but you can actually see where these neighborhoods are in Ontario, and they do break them down by these 5 quintiles across Ontario for each of the 4 dimensions of the index. So that can help with some targeted outreach as well. We didn't specifically get into that in this study. We didn't want to, I did some media after this was first published, and we didn't want to get into what are the bad neighborhoods or what are the worst off neighborhoods, because that wasn't the focus of this study. But I think in terms of trying to take this and make some policy change, you can actually identify what neighborhoods would benefit the most from some interventions.
Did you have any more, Monica?
No, but I have a personal question I think might be helpful I would like to ask. So for those that who are, actually there's some chat questions coming in actually. I'll ask this one first. So someone asked, based on your experiences, would you recommend to the researchers, based on your experience, would you recommend to the researchers in the audience that they make use of the Ontario Marginalization Index despite the limitations?
Yeah, so I'm just getting a little bit of background noise, but we haven't really got into what the challenges of this study were. And I would say one of the challenges was working with the Ontario Marginalization Index. I think a good lesson learned for me was that I had read a lot about it. So I saw it in public health avenues and I thought it was a very well-known index, but when I actually went out and started presenting research outside of our public health circles, so we'd go to a primary care conference or another jurisdiction outside of Ontario, it wasn't as well known. So you'll see in the paper, I actually spent a lot of time talking about what the components of the marginalization index are, how it's been validated previously. I think almost in every section, like introduction, methods, and discussion, I talk about how this was a validated tool because we got a lot of pushback saying that this wasn't a validated index, even though it has been. And then lots of questions as well of why wouldn't you consider these measures and their individual constructs, which unfortunately you just, Public Health Ontario hasn't allowed us to do that with their data. And then also why wouldn't you consider this just as a global marginalization score? So summing up all 4 dimensions. And the reason for that is you can't sum them all up when you have some differences in effect of the different dimensions. So after going through the peer review process and really having to explain this, I kept building upon our paper, which I think made it stronger to give more information on what it is. And I'm still a fan of using this index because I think it's very powerful, provides a lot of information, but recognizing that if you were to use it, it's not as well known as I thought it was, and to just keep that lens in any of the work that you're doing, that you do need to defend your methods and can't make those assumptions that everything you're doing is well known to the reader or to the conference participants that you're giving a presentation to.
I'm also curious to know, just based on, so, because you've mentioned that you get a lot of pushback with the marginalization because you thought it wasn't all known. I'm curious to know, especially at conferences thinking about primary care settings, you also mentioned in your article, you talk about your diagnostic criteria that you use, so using the ICD-9 and ICD-10 in the administrative. Mm-hmm. And so did you have a lot of pushback there in terms of thinking about, because I know you use longitudinal studies, so you're looking at data from 1993 to 2014. Mm-hmm. There's a lot of diagnostic criteria can change in between that time, especially when you're thinking about associated comorbidities with avoidable mortality. So that's something that also came up as a potential limitation, was knowing the two different diagnostic criteria in those years.
Mm-hmm. Yeah, were there any particular like chronic conditions you were thinking of that might have changed over that time? I have some ideas myself.
Not any that come to mind right now, but I just was mostly thinking about the criteria change in that year period, how it was measured differently between the two ICDs.
Okay. Yeah, so I have my paper in front of me. One of the figures, if you guys have the paper in front of you, shows you what the avoidable mortality trends are, so figure 3. And you can see there's really 2 time periods that have like this weird change in the trends that were otherwise quite linear. So 2000 and 2013. And there were 2 big reasons for that. In 2000, there was a switch internationally from ICD-9 to ICD-10 codes, or at least that's the year Ontario switched their coding. And that like coding has an effect, and you can see that quite clearly in the figure that there was a bump up, it looked like, in overall mortality, but it was a change in how we coded deaths at the time. And then another change was in 2013, and that's how Ontario changed their criteria for classifying deaths through their mortality database. And again, big change in the figure when you take a look at it. So recognizing those differences, we conducted a sensitivity analysis because we just wanted to make sure that the trends we were observing were still statistically significant. So we did a sensitivity analysis, removing 2013 and 2014 from the data, and found there were no changes. In terms of like individual level, like chronic conditions, so we included a fair number of chronic conditions just based on the fact that your health status has an impact on your mortality. I can't think of like a specific example of where there was major changes in the diagnostic criteria, but I wasn't a practicing clinician through the 90s or 2000s, so don't really know the historical context there. I do know the DSM-5, which is how we classify psychiatric and mood disorders, was changed in 2013, so probably not a huge impact on this study. I think what a bigger impact is probably just things like greater awareness of mental health and mental health illness, and then how that impacts clinicians at the individual level making those diagnoses, which are then captured in this type of administrative data.
I think it was really interesting, and we've talked about this before, is just, yes, we've known that like non-communicable diseases have been on the decline over time since the 50s. We've had better medicine, we've had more awareness, using preventative medicine and public health more. But that image, the figure you included, is really interesting, just from 93 to 2014, how much a decline you also had there in those chronic diseases, and from avoidable mortality as well, deaths from it.
Yeah, and this is, again, just a snapshot from a 25-year period. There's other studies that have published on avoidable mortality trends previous to this, which I think I've cited in the introduction if you're super interested, but you can actually see even prior to this time period, there were very similar trends. So it really goes to show the advances we've made as a society to decrease these avoidable deaths. Still with some room to grow to improve things.
Mm-hmm. So talking about health outcomes in general, how do you think, and we might have kind of touched on this briefly already in one of the questions, but how might this study or these types of methods inform research on avoidable health outcomes and not just avoidable mortality?
So I think it was nice to see the diversity of people and what they were interested in at the beginning through the poll, like a big interest in policy, programs, and research. So I think you can come at it at a lot of different lenses. One, I think, is just a research methods lens for future clinicians or researchers that want to use these types of indices to measure avoidable health outcomes. So as I had mentioned earlier, not a ton of research out there on neighborhood level marginalization that looks at studies with these composite measures of marginalization. So I think one thing that the study can provide some guidance on to future researchers is, how do we use these composite indexes? What are some things to think about? Like if I was to do the study again, I might not use the dependency variable, knowing now that it is like having that age-based exposure and age-based outcome didn't really make a lot of sense. So we've commented about that in the discussion for future researchers, just to give them some tips for future research. Perhaps another type of avoidable health outcome, you could actually see the same direction effect for all 4 dimensions, and then you can start doing some publishing on summary measures of marginalization, which would also be very interesting. Or you could even break down each of those components and see, is there a particular part of material deprivation that is really driving all of these avoidable or particular avoidable health outcome? And then to answer Yipeng's question from earlier, often when you're trying to make some policy change, it's really useful when there's something targeted you can point out. So is it the single parent households that are having the highest avoidable mortality rates? And then that could be an easier target for intervention, as opposed to just saying all of these, like all of material, this is like a very materially deprived neighborhood. What is the particular intervention might be a little bit harder to decide.
Were there any, that off the top of your head, were there any examples of policy interventions that you think that might be implemented to help improve outcomes for those who were residentially unstable?
Yeah, so I would say policy implications were a little bit out of scope for our paper, but certainly could extrapolate the research a little bit if you like. I don't think it would be anything groundbreaking that us as public health practitioners aren't already advocating for in our communities. So trying to find stable housing for those that are marginally housed, or those that have to live in very overcrowded housing, finding stable housing for them, having policies in your community that allow for a mix with low income or affordable housing. So I would use my research, I think, to continue to promote existing public health policies that others are advocating to address these issues.
Monica, did you have any more questions from the chat?
Yes, we have a few more from the audience. So one for our methods friends. So what does your modeling approach look like? Did you put everything in from the beginning, or do any variables, or are there any variables that you think didn't make it to the final stage?
Yeah, so that's always a super interesting question when developing your methods, because the ideal scenario is you will write out your entire proposal, run it by your committee or your team, and then run the analysis, and you won't make any changes because you don't want to be finding associations when they might not exist there, or taking out variables that aren't statistically significant, that type of thing. So I would say, like, we used the administrative data available to us through the ICS. These are very standard variables. So age, sex, urban, rural health status, and the total number of chronic conditions. In terms of changes we made, so initially we had considered the individual chronic conditions, so like 18 chronic conditions on their own in the model, which in the end didn't really make a whole lot of sense. So we decided just to group them into a level of comorbidity. And that showed us, I think, a better picture of health status looking at multiple morbidity. And then the other variable that we had included in the study that's no longer there is individual level income. Just given the previous associations of income with avoidable mortality, we thought it would be important to include. But when you look at the material deprivation index, like there are several components in there that include income. So we were challenged during the peer review process of why, the peer review process at CJPH, so we can talk about that later. But they challenged us to say, like, why would you include this variable when you're already capturing it in another dimension, and you've not provided a good enough argument of why the two are different enough to warrant including both individual level and neighborhood level income. And after reflection on that, we did remove income from the model, and I think that was an appropriate decision.
Perfect. And we have, I believe we have about 9 minutes remaining in our session. Time goes by very quickly. And there's a question in the chat that's very long to read. I can read it out for you as well, but you might want.
I can open up the chat.
We can look at that.
Maybe you can read it. I don't know if everyone can see the Q&As, can they?
So the question is, considering the modest protection given by the visible minority population being more likely to seek practitioner care, did you see any increases in risk factors within the communities that had a lower concentration of visible minorities? And then another question that was also asked by multiple attendees was, they're also curious to know if you have any thoughts on whether the results can be used to how they can be used to deal with the current pandemic, given that we know that marginalized populations are disproportionately affected. So,
so to answer the first question on risk factors in communities with a more homogeneous mixture or low concentration of ethnic diversity, that wasn't something we looked at, so I can't provide any comment on associations there, but I think a super interesting question. And if that's something that interests you, let's touch base offline, James, and maybe there's a study there that we can work on. In terms of the applicability to the current COVID pandemic, I think at least here in Ontario, we've published a lot of data on the types of individuals who have tested positive for COVID, and I think other jurisdictions in Canada and internationally are doing that as well. And we've seen that those that come from marginalized groups have tended to have higher rates of COVID-19 and also poorer health outcomes from COVID-19. And there's a lot of reasons for that. Like, this is an infectious disease that is highly transmissible. So if you live in a residentially unstable neighborhood, or you live in a household where there's a lot of people, COVID's going to easily spread amongst those groups. And we've seen that in a lot of shelters here in Ottawa and other residential unstable neighborhoods too, based just on neighborhood level data that Ottawa Public Health is publishing. And then other factors as well. So you think of other risk factors like material deprivation. And one thing we've seen in risk factors for COVID are like people that have low income and need to work multiple jobs. So then they're at higher risk of being exposed to COVID-19 from having to work in multiple places. So I'll leave it there before I get derailed on COVID-19 and marginalization. That's super fascinating. I think
one last question from ours. And then if we have a little bit of time, Monica, if that's good for you.
Could you do it in about 1 minute? Is that perhaps I just want to...
Yeah, so I just wanted to ask you, Austin, why did you choose to submit this to CJPH? And why do you think that the paper was chosen for publication?
Yeah, so CJPH, I think, really just seemed like a natural fit for this paper. When you think of the journal, it's really like the top public health journal in Canada. So when I was looking to publish my research, I was like, well, I'm going to aim high and go for the top journal in Canada. So it worked out pretty well that way. And I would say, like, I've published other studies before in other journals, and the peer review process at CJPH was very, I think, professional, and also from a perspective where they really wanted you to improve your paper to make it the best for the audience. So I think some of the feedback I got from the editors during the peer review process were super useful and made for a much better paper in the end, compared to other papers I've submitted to other journals, which have really just been a list of critiques of why your paper is no good, and that they thank you for submitting, but don't really give you a lot of information on how to make it better. So certainly encourage everyone to apply to CJPH for your research, because I thought it was super useful. On the question of why did they pick it, I don't know, you'd have to ask them. I like to think it was a great article.
I just think it's novel, so there you go.
I agree with that. Thank you so much. So I know that there are likely lots more questions that haven't been able to, that we didn't get to discuss today, but I encourage you to continue this conversation on Twitter. We're more likely to answer more questions or have larger discussions around the methods or findings, or maybe potentially even applicability to COVID-19. I think that'd be a great discussion to continue on Twitter.